Good evening and welcome. I'm Jean Johnson, one of the librarians at Stanford Health Library. Thank you for joining us for tonight's talk, Osteoporosis Prevention and Treatment. It is my pleasure to introduce our speaker, Dr. Joy Wu. Dr. Wu is a board-certified endocrinologist who specializes in treating osteoporosis and other bone and mineral diseases. She is chief of the Division of Endocrinology, Gerontology, and Metabolism, and vice chair of basic science in the Department of Medicine at Stanford. Dr. Wu's laboratory is currently studying stem cell therapies for bone formation and the prevention of cancer metastases to bone. Throughout the program, please enter any questions in the Q&A box at the bottom of your screen. And at the end of the talk, Dr. Wu will try and answer as many of those as possible. Okay, Doctor, I turn it over to you.
Thank you, Jean, for that kind introduction. It's really a pleasure to be here. It's always a pleasure to talk to people about their bone health, and the Stanford Health Library is such a valuable source of information for the public. So again, really grateful for the opportunity. All right, so the topics I'd like to cover today include the definition of osteoporosis and who should be tested for this, what can we do as individuals to improve our bone health, and finally, a bit of a discussion about, when is it that we need to think about medication and how can we do this safely? All right, let me start with the take-home messages. I would love for everyone to come away with the understanding that fractures are serious due to osteoporosis, but in fact are preventable. That osteoporosis affects not only women, but also men. The risk factors that influence your fracture risk, there are many of them, and we'll review some of those today. Lifestyle changes can certainly slow, but usually not fully reverse bone loss. And finally, when used properly, osteoporosis medications can, in fact, be very safe and effective. So let's start with the definition of osteoporosis. It's a disease of skeletal fragility. Here is a photograph rendering of what your bone looks like under the microscope, and you can see normal bone has a lot of connections and plates and rods, and I think you can appreciate in this rendering of osteobone that the amount of bone is less and that these rods are thinner. And in fact, osteoporosis literally means porous bone and refers to a decrease in bone mass that leads to increased fragility and likelihood of fracture. To put osteoporosis in perspective, it's very common. 34 million Americans are estimated to have low bone mass. Compare this to a very similar number of individuals who have high blood pressure and just slightly less than those who have high cholesterol. So a very common public health problem. What's not always appreciated is how devastating osteoporosis can be. The most significant kind of fracture is a hip fracture, of which there are about 250 to 300,000 cases per year. And the 1-year mortality is really shockingly high after a hip fracture. It can be 25% or more. And if you compare that to other diseases for which we think of as having serious impacts on health, there are about 700,000 heart attacks or myocardial infarctions a year in the US, for which the 1-year mortality now is less than 10% because of the outstanding work in both prevention and treatment. There are a similar number of invasive breast cancer cases, advanced breast cancer cases diagnosed each year, 230,000. And this is a case in which the mortality is also pretty high after 1 year, about 20%. The lifetime risk for osteoporosis for women is 50%. So 1 in 2 women will have a fracture due to fragile bones or osteoporosis. Compare this to a 12% or a 1 in 8 chance over a lifetime of being diagnosed with breast cancer. I alluded to the fact that men are also at risk for osteoporosis. About 20% of men can expect to sustain a fracture in their lifetime due to osteoporosis. And this is more on par with the rate of diagnosis of prostate cancer, which is quite common in men. So this is a photograph of a fracture cast. I think in the back you can see a person standing there to give you some sense of how high this is. This represents the 5,500 fractures that occur every day in the US due to osteoporosis, which is more than 2 million per year. So osteoporosis is in fact a major public health burden, affecting more than 10 million Americans, 80% of whom are women. On the previous slide, I showed you there are more than 2 million fractures per year. And this number representing the direct cost per year is now far outdated, probably well exceeds $20 to $25 billion in cost per year. The kinds of fractures that can occur with osteoporosis vary. There are a number of sites. Perhaps the most common is a vertebral fracture or a spine fracture. Also common sites are wrists, especially I trained in Boston, and it's quite common in the winter to slip on a patch of ice and land on your outstretched hand. So this can lead to wrist fractures. We've talked about how hip fractures are particularly devastating, likewise pelvis fractures and other types of fractures. The kinds of fractures that occur with osteoporosis can change over the lifetime. So wrist fractures are most common in relatively younger women, those in their early 50s and 60s. And again, I think that's because if you were to slip and fall on the sidewalk, younger women are able to get their hands out. They have the reflex time to put their hands out to break their fall, and often will fall on their outstretched hands, leading to a wrist fracture. Spine and shoulder fractures are a little bit more evenly distributed across ages. Whereas hip fractures really are mostly limited to the elderly population over the age of 70 to 75. And I think as you get older, the balance gets worse, the frailty gets worse. And if somebody were to trip and fall, they're less likely to be able to catch themselves, less likely to be able to break their fall with their arm, and more likely to fall directly on the hip, leading to a hip fracture. So a little more about osteoporosis in men. About 1/3 of hip fractures do occur in men. Men suffer almost 600,000 fractures a year, of which about 75,000 are hip fractures. What's particularly alarming is that men are more than twice as likely to die after a hip fracture, but less than half as likely to receive treatment for osteoporosis. So increasing public awareness that osteoporosis affects men is a high priority of mine. Jean mentioned in the introduction that my laboratory is very interested in breast cancer and bone metastases. In my clinical practice, I focus on osteoporosis in patients who have breast and ovarian cancer. And in particular, women, mostly women, there are men who have breast cancer. In women who have breast or ovarian cancer, they can be at risk for bone loss for a number of reasons. Many women are treated with chemotherapy, which is quite toxic and can be tough on the bones. The chemotherapy can lead to premature menopause from the stress, the biological stress of the process. Because many breast cancers are treated with endocrine therapy to block estrogen, which leads to bone loss, that can also increase the risk of fracture. And finally, many individuals with cancer are treated with radiation therapy, which also can result in bone loss. So this is just a figure showing in light gray survivors with breast cancer and comparing their fracture rates, which are significantly higher than reference control individuals without breast cancer. And to stay on the topic of cancer and bone loss, again, to make the point that those individuals who are treated with endocrine therapy are at particular risk. So let me start by reviewing the normal rates of bone loss. In men, it's about 0.5% per year. Women have a period around menopause when the estrogen levels fall pretty abruptly. And so the rates of bone loss during menopause and after can be as high as 1% to 2%. This is sort of naturally occurring bone loss here in green. But shown to the right in blue are bone loss that result from cancer therapies, and highlighted in the red boxes are endocrine therapy relating particularly to breast cancer. So aromatase inhibitors are a common way to block block estrogen levels in individuals with breast cancer. And you can see that the rate of bone loss is higher than naturally occurring bone loss after menopause. The greatest bone loss comes in younger premenopausal women who either are put on aromatase therapy and ovarian suppression to prevent cancer recurrence, or who have chemotherapy-induced premature menopause. And you can see that these rates of bone loss are really dramatically higher than naturally occurring rates. All right, so let's talk about who should be tested, who's at risk for osteoporosis, and who should be tested. So there are a number of risk factors that increase a person's chance for having fractures. Probably the greatest is age. The older we get, the higher the risk of fracture for a number of reasons, because bone density goes down, because muscle strength goes down, because people become more frail, balance goes down, and all of those things lead to increased risk of fracture. A history of a previous fracture is also a very important risk factor. So if you were to look at individuals who have a hip fracture and go back in time, about half of those individuals previously had some other kind of fracture, for instance, a wrist fracture or a spine fracture. I showed that wrist fractures happen more in younger adults around the ages of 50s to 60s. And, it's particularly sad when somebody comes in with a hip fracture or and you learn that there was a history of a previous wrist fracture, and they say, well, but I slipped on the ice and I fell really hard. But the reality is you should not break a bone if you're falling from standing height or lower. Of course, if you fell off a 10-foot roof or were involved in a motor vehicle accident, that's certainly a higher level of trauma. Other things that increase your risk for having bone loss and fractures include medications, particularly glucocorticoids. So these are commonly known as steroids. They include medications like prednisone, methylprednisolone, solumedrol. A family history is important, particularly if you've had a parent who had a hip fracture. In the medical field, we spend a lot of time discussing with patients how excess body weight can be associated with risks, but osteoporosis is a case where being too thin actually raises the risk of bone loss. Smoking, excessive alcohol intake, rheumatoid arthritis, and other inflammatory diseases, and finally secondary osteoporosis, which is osteoporosis relating to other conditions or medications. It's important to identify those who have these risks for fractures because, again, if you look at all hip fractures, they occur from a relatively small fraction of the population, and many of these individuals have previously had a fracture, whereas half of the fractures occur in the rest of lower risk individuals. So our gold standard test for identifying individuals at risk for osteoporosis is called a bone density test. It's also referred to as a DEXA scan, that stands for dual energy X-ray absorptiometry. The general recommendations from a number of professional organizations devoted to bone health suggest that women who are 65 or older and men who are maybe 65, 70 or older should be referred for a screening bone density test. In addition, younger postmenopausal women or men between the ages of 50 and 69 who have significant risk factors like the ones we discussed before. So medications that cause bone loss, cancer treatment, other conditions like rheumatoid arthritis, history of tobacco or heavy alcohol use. Those would all be reasons to consider earlier screening. And finally, what's often missed is individuals who've had a low trauma fracture or what we call a fragility fracture after the age of 50. So not counting, broken arms that happened when you were a child or teenager, but as an adult after the age of 50, if you've had a fracture that really happened without a lot of trauma, that's an indication to get a screening bone density test. And then finally, as we talked about, there are conditions like rheumatoid arthritis and medications like glucocorticoids that can also be associated with bone loss. So what is a bone density scan? This is a photo taken with permission from our scanner here at Stanford. It's basically a bed with an arm around it, and it takes pictures of the spine and the hip and calculates the bone mineral density. Sometimes on rare occasions, we also measure the wrist. The bone density is measured in terms of T-scores, which are standard deviations compared to reference adult populations. Excuse me for 1 second, I'm going to take a drink. Water. Thank you. So as you can see here, adult bone density is highest in young adults, matched for gender and perhaps race and ethnicity. With age, there's a gradual decline. In women, there's a more rapid decline around the time of menopause, and then it evens out again over time. So in the hip, we measure the femoral neck, which is the thinnest part of the hip joint, as well as the total hip. And in the spine, we measure the lumbar vertebra, L1 to L4. And the World Health Organization defines osteoporosis as a T-score that is 2.5 standard deviations lower than that of a reference young adult. If you have an intermediate bone loss, something we call osteopenia, that's a T-score of -1 standard deviation to -2.5. And if your bone density is greater than 1 standard deviation below the reference adult, then your bone density is considered to be normal. This is a non-invasive test. It doesn't hurt. You lie on this bed for about 10 minutes and you can get these results. So I'd like to spend a few minutes talking about the fact that your fracture risk depends not only on your bone density, which is measured by DEXA, but also on age. So here is a chart showing bone mineral density T-score decreasing towards the left. So on this direction is the most severe, a T-score of -3.5. And then on the y-axis is your risk of having a hip fracture over the next 10 years as calculated by an algorithm we used called FRAX. And this is for a woman who is 150 pounds, 5 foot 6 inches, and I've plotted her risk over different bone density scores at a variety of ages. So first, let's look here at a T-score of -2.5, which is what the World Health Organization defines as osteoporosis. And the recommended threshold for treatment is when the 10-year risk of having a hip fracture is at 3%. Now, that might sound like a very low number, but again, remember that I showed that the effects of a hip fracture are really devastating at 20% mortality rate. So we really want to set this threshold very low and try to prevent as many as we can. So at a T-score of -2.5, a 65-year-old woman shown here in this sort of dark blue black band will cross the 3% threshold right at a T-score of -2.5. So a 65-year-old woman who has a T-score of -2.5 or a diagnosis of osteoporosis by bone density would merit treatment. If you are younger than 65, your bone density can be lower. It can be almost as low as -3.0 before you reach that threshold. So sometimes I see younger women in my clinic who, for whatever reason, have had a bone density and have been identified as having, a T-score of -2.7, -2.9, technically in the osteoporosis range. But if we calculate her risk because she is so young, she's relatively protected. And I might say, we don't need to treat right away. We can watch for a bit. But the converse is also true. And what I want to show you here is on the far right, a woman at age 80 can have a near normal bone density, T-score of maybe 1.3, 1.4, and still reach that risk threshold of 3%. And again, that's because there are many other factors that go into your risk of fracture, and these increase with age. So often we'll see an older adult who has fallen and had a wrist fracture or maybe has had a spine fracture, and the primary physician very appropriately orders a bone density scan. But then when the results come back as osteopenia, the patient might be told, oh, everything is fine, don't worry. But in fact, if you've had a fracture or if you are older than 75 or 80, it could well be that you could be at risk for osteoporosis, even without a very low bone density score. The other point I'd like to make is the number of risk factors you have also significantly matters. So again, this is the same woman at age 65 for a given height and weight, looking at the number of risk factors that she has. And you can see that if she only had 0 or 1 risk factor, she might not reach the treatment threshold, but at 2 and more, that risk significantly increases. So the more risk factors you have for osteoporosis, the greater the chance of fracture. All right. It's also important to note that while having a very low T-score is a risk for osteoporosis and fractures, having osteopenia or osteoporosis doesn't mean, having osteopenia or a more normal bone density does not always mean that you're in the clear. And that's because about half of fractures actually occur in individuals who have osteopenia. And that's a function of the fact that a much larger percentage of the population has osteopenia than osteoporosis. So even when you have osteopenia, you can be at risk for osteoporosis. And that's the reason that we assess all the other risk factors to try to stratify those individuals who are at greatest risk. All right, now we can talk about things that we can do to improve bone health. So the Surgeon General's report has several recommendations. Getting enough calcium and vitamin D, we'll talk on the next few slides about what that means. Being physically active, reduce your risk of falls. So this means things like if you have loose throw rugs throughout your house, to make sure that they are either tacked down or stuck to the floor, that you don't have loose rug corners on which you might trip. Things like having good railings and banisters on the stairs. At night, having a nightlight to the bathroom. A surprising number of falls occur in older adults because they were getting out of the bed to go to the bathroom in the middle of the night. It was dark. They might be a little bit sleepy. Their balance isn't so great. Maybe the dog is lying on the floor next to the bed. And so that is a very common scenario for older adults to trip and fall while going to the bathroom. So having a night light to allow a little bit of visibility is important. Maintaining a healthy weight, that means not too thin or not too overweight. Don't smoke or stop smoking if you do. Limit alcohol use, no more than a drink a day for women, 2 drinks a day for men. And finally, we discussed that several medications and diseases can be associated with bone loss. So bringing that to the attention of your physician to talk about bone health. All right, let's talk about calcium. Calcium is part of the mineral in your bone. The reason your bones are so structurally hard is because they're largely composed of calcium and phosphate mineral deposited as something called hydroxyapatite. And calcium is the part that we have some control over how much is deposited. So a general guideline is that we should be aiming for 1,000 to 1,200 milligrams of calcium per day if you're at risk for bone loss. And this can be from dietary sources or from supplements. So if you want to take dietary sources, you can see that dairy products, milk, yogurt, cheese are really a wonderful source of calcium. On average, 1 serving of dairy, so that's a cup of milk, a cup of yogurt, an ounce or 2 of cheese, have almost 300 milligrams of dairy. So if you were to have 2 to 3 servings of dairy a day, you would really have very sufficient calcium intake. Calcium can also be found in other foods. Many juices and cereals are fortified. If you like canned salmon, especially with the bones, that's a good source. Dark green vegetables, broccoli, kale are also a great source, just not as concentrated as dairy products. Now, many adults, especially on a Western diet, don't get 3 servings of dairy products a day. And if that's the case, you can also take supplements, or maybe you have lactose intolerance. Perhaps you're on a vegan diet and dairy is not part of your dietary intake. And so that's fine. You can do calcium entirely based on supplements. The important thing to remember is you want 1,000 milligrams a day, but your body can really only absorb about 500 milligrams at a time. So if you are taking only supplements, you need to divide it into 2 doses, roughly 500 milligrams at a time. If you happen to be taking medications for acid reflux, so things like proton pump inhibitors or H2 blockers, then you should take a form of calcium called calcium citrate. Otherwise, calcium carbonate is the most abundantly available. It's over the counter. It is less expensive, and that's a perfectly fine supplement. You also need vitamin D. Vitamin D acts on the intestines to help absorb calcium. And a general guideline, again, for individuals who are at risk for bone loss is a goal of 800 to 1,000 international units a day. So to keep things simple, I generally tell my patients to remember 1,000 milligrams of calcium and 1,000 units of vitamin D. So vitamin D can come as a plant-based supplement, which is vitamin D2, also known as ergocalciferol. Probably more commonly, you'll see vitamin D3 on the shelves of your pharmacy, cholecalciferol. This is the version that we produce in our skin when we are exposed to sunlight, and is an animal-based form. Either of those is fine, and you can take all 1,000 all at once, or you can buy calcium supplements that have the vitamin D divided into those doses and take those as well. Next, we have to talk about physical activity. As you know, when we send our astronauts up into space, they can rapidly lose bone. And in fact, I read somewhere that the astronauts on the International Space Station devote about 3 to 4 hours per day to rigorous activity so that they can maintain their bone health when they come back to Earth. So the American Heart Association recommends 150 minutes of moderate or 75 minutes of vigorous activity a week. I tell my patients to aim for 30 minutes a day. So that can be walking, it can be tennis, swimming, anything that you enjoy. The important thing is to do something, an average of 30 minutes a day per week, every week. In addition, for bones specifically, it can be very beneficial to do strength training. And I recommend 2 to 3 times a week. These can be with free weights. These can be at the gym using weight machines. They can be resistance bands. You can get them on Amazon for a few dollars. You can get a bag of resistance bands that have different degrees of stretchiness. There are also many videos available online that have body weight exercises. So things like squats, push-ups, you can get a very effective strength training routine without any kind of equipment at all. I also counsel my patients that balance and flexibility are very important. Things like yoga and Pilates and stretching can be very beneficial. So if you're looking for resources, the Bone Health and Osteoporosis Foundation is a patient-facing organization that has some great tips on osteoporosis in general, but they have a nice guide to exercise. And then I like this website, melioguide.com, which is written by a physical therapist who specializes in osteoporosis and provides some nice guidance on exercises. All right. Sometimes lifestyle changes are not enough. You can have all the calcium and vitamin D, you can do all the right exercises, but you might just have either such a low bone density or a calculated risk that is too high, and we really have to think about treatment. So how do we make those decisions? Who is at need for treatment? So again, we talked about how individuals who are women over the age of 65, men over the age of 70, or those who are younger with risk factors or a fracture history should have a DEXA scan. Those who have osteoporosis, a T-score of -2.5, or who have had a previous fracture, a hip, spine, and that can either be clinical, which just means that you knew you had the fracture, or radiographic. Sometimes spine fractures, surprisingly, are what we call silent. People don't realize that they've had a spine fracture. It's just visible on X-ray. So this category should be considered for treatment. If you have osteopenia, then we recommend using that FRAX calculator I showed a few slides ago to calculate the 10-year risk of fracture. And if it exceeds 3% for hip fracture or 20% for all major osteoporotic fractures, then also you fall into the group for which we should consider treatment. So just a little bit on medications, because that's really more of a discussion for your doctor, but just so that you're aware of what exists out there as options. So I tell my patients that the amount of bone that we have is really determined by the balance between how much bone is formed versus how much bone is broken down. So we have cells called osteoblasts in our body that make bone, and we have cells called osteoclasts that break down the bone. And I use the analogies of the bricklayer for bone formation and the jackhammer guy for bone breakdown. So really, it's quite simple. If we want to treat osteoporosis, we can either stop the jackhammers, we can block bone breakdown, or we can promote bone formation. Now, by far, the most medication prescriptions are written for these medications here, which block bone breakdown, what we call anti-resorptives. The anabolics are really reserved for very severe cases. This is a summary table of osteoporosis medications. In pink on the top are the anti-resorptives. These, again, are the most commonly prescribed medications. They include oral bisphosphonates. You may be familiar with Alendronate, which is marketed as Fosamax, Risedronate, marketed as Actonel. There's an intravenous form, zoledronic acid, Reclass. These are very, very safe and effective medications. They are our longest standing osteoporosis medication. For the oral medications, they sometimes cause heartburn or GERD, gastroesophageal reflux disease. They can't be used in individuals who have renal kidney problems. And if somebody has heartburn or GERD, then we recommend intravenous bisphosphonate, also known as reclassed, again, cannot be used in individuals with poorly functioning kidneys. A newer medication in this sort of group approach is denosumab, marketed as Prolia. The nice thing is it can be used in individuals whose kidneys are not functioning at 100%. The important thing to remember for Prolia is it cannot be stopped abruptly, and there's a little bit of caution for those who are immune compromised. The anabolic or bone-building medications shown in green, we have three options. Two of them are very similar, Forteo and Tymlos, and they're all very effective. These two do require daily self-injections, so you can imagine that's not a super popular option, and again, why we reserve it for more severe cases. The newest entrance on the market is romosozumab, marketed as Evenity. Causes very rapid reduction in risk, which is great if somebody is at high risk. It does carry a box warning of risk for some cardiovascular adverse events. These are monthly injections. Highlighted in bold are the ones that are also approved for men. So all osteoporosis medications are first tested and approved by the FDA in women with postmenopausal osteoporosis, and then often the companies will seek approval for osteoporosis in men. I do want to make the point that since I discussed the risk of bone loss in cancer patients, particularly those undergoing endocrine therapy, that it's really the anti-resorptives that are preferred options for individuals with cancer. And finally, the sequence matters. All you need to know is that if you are ever started on one of these anabolic agents in green, it must be followed by an anti-resorptive. If you were to stop after this 1 to 2 year period, the new bone would go away very quickly. And considering that two of them require giving yourself injections every single day, that would be very disappointing. So you want to immediately switch to an anti-resorptive. It's also important to note that if that anti-resorptive is denosumab, which is Prolia, which can be safely given for 5 to 10 years, it cannot be stopped abruptly. So after that, you also need to switch to one of the oral or intravenous bisphosphonates for maybe up to a year. But again, these are details to be discussed with your physician. And finally, in the last few minutes, I want to address the issue of whether osteoporosis medications are safe. I see only osteoporosis patients in my clinic, so I've really heard all of the concerns. And it's quite common for individuals to come to me and say, I prefer natural remedies, I'm sensitive to medication. I've read that they can be dangerous, or understandably, I know somebody, a relative, a friend who took the medication and had an unpleasant side effect. So I certainly appreciate that there's a lot of concern about taking medication in general, and with some of the rare side effects of these medications, one of which is a condition that affects the jaw called osteonecrosis of the jaw. This has led to a great deal of worry among patients and their dentists about whether they can safely take these medications. And I just want to point out that the American Dental Association issued a statement that said that discontinuing osteoporosis therapy might not eliminate the risk, because this condition does occur even without these medications. However, it's important to remember that discontinuing osteoporosis treatment can have a very negative effect on the treatment of low bone mass. So essentially it can, raise your risk of fractures. So just advising some caution in asking people to stop. So I think a more helpful way to think about it is, what are the benefits versus risks of treatment? So shown here in gray in the first three are spine, wrist, and hip fractures among patients treated for 100,000 patient years. So this could be 10,000 women treated for 10 years. You can see there would be several, if they were untreated, there would be several thousand spine fractures, wrist fractures, hip fractures combined. But if they're treated with osteoporosis medication, this difference is the reduction in the number of fractures, and that's pretty significant. Compare that with the risk of the rare side effects, osteonecrosis of the jaw and atypical fracture. And again, these are extremely low, and they're broken down by treatment duration. So more than 10 years is what it takes to see any detectable rates of atypical fracture. And you can see that's far less than your risk of being involved in a car accident. I think this is also another way to visualize it, which is if you were to treat, say, 1,000 women over 10 years, these are the number of fractures that you would prevent. Again, remember that 1 out of every 2 women is going to experience a fracture in their lifetime from osteoporosis. So these are the number of fractures that you would prevent. These are the number of cases that you might expect to see of osteonecrosis of the jaw, and if treated for 5 years, atypical fractures. So I think the important take-home point is that in appropriate individuals, the benefits of 5 years of treatment really far, far outweigh the risk. And with that, I will come back to my take-home messages, which are that fractures due to osteoporosis are serious but preventable, and in fact are not an inevitable part of aging. I hear from many people that, my mother, my aunt, my uncle fell and broke their hip or their wrist or something, but they were older and they fell. But that really should not be an expected part of aging. There's a lot we can do to mitigate that. Remember that osteoporosis affects not only women, but also men. Your risk of fracture depends on a number of factors. Lifestyle changes can indeed slow, but usually cannot reverse severe osteoporosis or bone loss. And when used properly, osteoporosis medications are extremely safe and effective. And with that, I will thank you for listening. And if I can figure out how to stop sharing.
Okay, we've got quite a few questions here, Dr. Wu. Let's start. How much milk do women over 70 need to drink?
So it's about the amount of calcium. So all individuals who are at risk for bone loss need to have about 1,000 milligrams of calcium. Here we go. 1,000 to 1,200 milligrams of calcium a day. And so milk is a very efficient source that provides about 300 milligrams. So if you didn't want to take any supplements, you could drink 3 glasses of milk a day.
All right. Currently, I'm receiving an annual reclassed infusion.
Okay.
What's the maximum number of times to receive this drug?
Right. So there's not a maximum lifetime number. I do recommend for my patients, and again, this is a case by case determination, but for most of my patients, after 3 to 5 infusions, yearly infusions, I will recommend what I call a drug holiday. So that means stopping the infusion for a year to 2. The reason we do that is because we know that if you stop the medication for a year, those already very, very, very low risks of osteonecrosis of the jaw and atypical fracture get reset to baseline after just 1 year of not having the infusion. After 2 years, the risk of having osteoporosis starts to rise again. So for most of my patients, I recommend a holiday of 1 to 2 years, and then you can safely restart and continue with another, say, 3 to 5 infusions.
All right. Why are TBS scans more widely known and used?
TBS scans?
That's what they have here.
Well, TBS scans, right.
Yeah.
So TBS is largely still investigative. It's another, everybody is trying to figure out ways to even better predict who is at risk. So TBS is it's a trabecular bone score. It's a radiographic software that can be added onto DEXA scans and may modestly improve the prediction rates. So that is, comes down, the software is very expensive. So every hospital has to decide whether or not it's worth it. And, so far the data are encouraging, but it's a pretty modest improvement in the prediction of risk. So I think, it's up to each hospital whether or not they want to carry it.
All right. Could osteoporosis be the cause of shoulder, elbow, or hand pain?
So osteoporosis usually is not a cause of pain. Pain is more likely to be due to something going on in the joints. So that would be osteoarthritis or maybe rheumatoid arthritis. Osteoporosis is silent, which is why we need to screen for it, because you really can't feel your bone density until, of course, you have a fracture, which is then very painful, and you don't want to wait until then.
What exercises should be avoided if you have osteoporosis?
So I try not to ever tell anybody not to exercise. So I think, if you look at the websites that I recommended, there are some guidelines about things. Often, individuals with newly diagnosed osteoporosis will ask me, can I still ski? Can I go horseback riding? And usually what I tell those individuals is, for instance, I am a big fan of skiing. I assume a risk every time I ski that, there could be a fall, there could be a fracture. If somebody is a skilled, experienced skier and they're willing to accept that risk, then, I think that's a personal decision. If you've been diagnosed with severe osteoporosis and you're wondering if you should learn to ski for the first time, I would say maybe get some management and treatment first. But I try very hard never to tell anybody not to do exercise.
Okay. Kind of related, why do so many hip fractures lead to death?
Yeah, it's really quite shocking, and the answer is not that it's not the hip fracture itself that caused the death, but often it's sort of the final straw in an older individual who's frail. So being bedridden, being in the hospital, being susceptible to infections or perhaps blood clots if you can't get up and walk around. It's sort of the cumulative effect of all of those hits to the body and the individual. So it is usually not the case that the hip fracture itself caused the death, but it's all of the downstream effects. And when you talk to people, many people will say, "Oh, my parent my grandmother had a hip fracture, and then she died," and that really should not be an inevitable link. So we of course want to try to prevent that.
Okay, are any of the newer medications for bone growth more effective than the older ones?
So, I mean, I guess more by, well, no. So, um, I- they're all effective. They all significantly decrease fracture risk. The newest medication happens to be what we call an anabolic, which is a bone building medication. So it acts maybe more quickly, but all of the medications are quite effective at lowering fracture risk overall. And personally, I prefer the medications that have been around the longest because we have the longest history of understanding how to use them the most safely, and understanding what the side effects are and how they can be managed.
Okay, does having a hysterectomy at 50 increase your risk for osteoporosis?
So the hysterectomy itself, which is removal of the uterus, should not really influence your osteoporosis risk. However, it's quite common to remove the ovaries at the same time as the uterus. Excuse me. And removal of the ovaries does cause loss of estrogen and bone loss.
All right. If you have a T-score of 3.3, is that considered severe?
I assume you mean a T-score of minus 3.3, so
Yeah, I would
standard deviations below reference adult range. Yes, that would be getting towards the range of severe osteoporosis.
Okay. How effective is weight-bearing exercise to prevent osteoporosis? Do you know?
I think that a healthy lifestyle can certainly be very effective at slowing the rate of bone loss. Certainly I gave the example of astronauts who lose a lot of bone. We also see counterexamples. So tennis players who start playing at a young age, their dominant serving arm is noticeably stronger than the other arm. So it certainly can have some effect. There was a study in Australia a number of years ago where they took a group of women around the average age of 65 and subjected them to pretty rigorous weightlifting. So not ginger 1 to 2 pounds, but sort of 80% of the maximum amount of weight they could lift for a given exercise with, as you might imagine, very, very careful supervision. And they had pretty substantial increases in bone density on the range of 5 to 10%, which is not that far off from what we can accomplish with medications. But that was, a very carefully done, supervised, and quite rigorous training program. So it may or may not be for everybody.
Okay, does having cortisone injections for bursitis pain register as a risk factor?
That's a great question. So many people get cortisone injections for joint pain and discomfort. For the most part, those injections should be really localized to the joint. We worry more about systemic dosing of glucocorticoids or steroids, so things that are taken orally or given intravenously. For the most part, local steroid injections should not be a significant contributor, unless, of course, you're getting many of them or very high doses.
All right. Is there the possibility of hip replacement as a protective treatment for someone with serious hip bone loss?
So I'm not an orthopedic surgeon, but hip replacement is really done more for arthritis. Or, if you've had a fracture, then of course there might be hardware that is implanted, but it is not done as a preventive measure for preventing hip fractures.
Okay. Is there a risk of too much calcium for heart health?
So there have been some studies that have purported to show an association between high dose calcium supplementation and worsening heart disease. Those have not been very rigorously done studies. they were sort of after the fact analyses of data that was collected for other reasons, which is not sort of the gold standard of how we do clinical research. That being said, if you look at those studies and you sort of take it, on face value that there is the risk, it really seemed to be associated with individuals who are taking very high doses of calcium, more than 3,000 milligrams a day. And I would never recommend that because that will, for certain, raise your risk of kidney stones. So, again, the amount of calcium is, roughly 1,000 to 1,200 milligrams.
Okay. All right. This might be, are there problems if you get 1,200, and they don't say what, from diet and still take 1,200 in supplements? I don't know if that's calcium or vitamin D.
Well, it's we don't really get vitamin D from diet, so I'll assume that the question is about calcium. So that means you're taking 2,400 milligrams of calcium, which is quite a bit. It's if you're really getting 1,200 milligrams in diet, it's not necessary to take the supplements. More is not always better.
Okay, someone is asking about OsteoStrong, a program that uses musculoskeletal strengthening. Do you know anything about that?
So I don't endorse specific programs, but I do endorse strength training. So if you assess the program and you find that it's a good strength training program that you think you might benefit from, that would be fine.
Okay, there's a question about, can you explain how much calcium can be absorbed at once?
Right. So your body can absorb maybe 500 or 600 milligrams. So the point is that if you're going to take all of your calcium as supplements, you need to divide it into 2 doses.
Okay.
You can't absorb the full 1,200 all at once.
Okay, let's see. Okay. What is your thought on adding vitamin K to calcium supplementation?
Yeah, so there is quite a bit of work going on looking at the role of vitamin K. It's quite common in supplements. It doesn't reach the level of rigorous clinical evidence for which calcium and vitamin D have. So I don't specifically recommend it unless you have a vitamin K deficiency, which is quite rare. I think it's unlikely to be harmful if it's in your supplement, but I don't specifically recommend it.
Okay. For an invasive dental procedure, how long before the procedure must the biophosphonates be retired?
Right. So there isn't, these complications, osteonecrosis of the jaw, are so rare that it's exceedingly difficult to do any kind of trials and understand them. And so there is no data to guide us on this. And in fact, again, the estimates of frequency are very, very low. So, I think that's a question to discuss with your dentist or oral surgeon. If it's a routine, cavity or cleaning root canal, that's really not any indication to stop. I think the exception are procedures that will drill down into the bone. So specifically implants, or maybe you might want to, take into account. And often then I've heard surgeons prefer anything from 3 months to a year. So.
Okay, great. What is your opinion about the value of collagen and oral connective tissue in increasing bone density? I'm not sure what that means, but maybe you do.
I'm not certain. I wonder if this person's referring to things like, well, actually, I've never heard of, I don't know if there's such things as oral collagen. I think I'm thinking of glucosamine chondroitin. There's no strong evidence to support them.
Okay. And how do studies define or validate that a fraction is due to osteoporosis?
So we define osteoporosis fractures as those that occur with low trauma. So the formal definition is standing height or lower. So if you tripped on the curb, if you slipped on ice, if you were just standing and fell. So, anything if you fell from a higher height, or if you were involved in trauma, a motor vehicle accident, skiing, sports injury, those would not be osteoporosis fractures. But we define them as, fragility fractures occurring without trauma.
All right. Let's see. What if one has different T-scores for the spine, the hip?
Yeah, that's a great question. So we do most commonly measure spine, hip, sometimes the wrist, and you'll get different T-scores. So it's the lowest T-score guides the decision making, and it predicts risk everywhere. So the spine is typically lower than the hip, and that's because you have more surface area of bone in the spine, and so it can rise and fall more quickly. And so it's quite common that I can hear from patients that they're concerned that they have a low spine bone density and therefore that they're at risk for spine fracture. That's a very logical assumption, but actually a low bone density anywhere predicts risk of fracture everywhere.
Okay, if I had a DEXA scan years ago that determined osteoporosis, should I have another to see if the results have changed?
Sure. If you've previously had osteoporosis on a bone density scan, it's probably a good idea. I typically recommend, most insurance companies will cover every 2 years. So that's typically the window after which I repeat bone density scans.
Okay. Do you still need to take calcium in some form while taking reclast?
Yes. The calcium, again, is what makes the bones strong, the mineral. That's what contributes to the hardness of the bone and its strength. And so if you're on treatment for osteoporosis, it's especially important to have plenty of calcium so that the treatments can work.
What type of milk is best to drink? 1%, 2%, or whole?
Doesn't matter. It's the amount of calcium in that. So
let's see. What is your understanding of the effectiveness of bioidentical HRT to help prevent bone loss or improve bone density?
So I'm not going to comment necessarily about bioidentical, but hormone replacement therapy in general. Although we're referring here to estrogens and progesterones are clearly beneficial for bone. That is the reason that women lose bone more quickly during menopause, is because estrogen levels fall. And so while HRT is clearly beneficial for bone, the Women's Health Initiative study now almost 20 years ago showed that there are other risks associated with HRT relating to cardiovascular disease, breast cancer. And because we have such effective treatments that treat bone loss themselves, I do not prescribe HRT for the treatment of bone loss. You can speak with your gynecologist. There are indications for HRT, particularly in women who have just gone through menopause, so early postmenopausal women who are experiencing very uncomfortable symptoms relating to the menopause transition. That is a very reasonable indication. But specifically for the prevention or treatment of bone loss, HRT is not a typical treatment.
Okay. Someone asked, why is running not considered weight-bearing for osteoporosis prevention?
Why is
running?
I mean, I think running is a terrific exercise. It certainly has great cardiovascular benefits. It will load a bit the lower body, right? Because you're pounding on the pavement. If you're going to do running, then it's important also to do upper body strengthening as well.
Okay, and I think this will be our last question. What are your thoughts on bone marker tests in addition to DEXA scan?
Right. So in certain circumstances, they can be helpful. But the challenge with bone marker tests is they are not uniformly applied, and they have quite a bit of variability. So I think the analogy that everybody thinks of is, in cholesterol testing, we prescribe medications to lower cholesterol, and we can very accurately measure the cholesterol levels, and they correlate with risk of heart disease. And we would very much like something similar in the osteoporosis world to correlate with fracture risk and to tell us whether our treatments are working. And the current markers are just not that sensitive and helpful, but in certain cases they can be useful.
Well, I really want to thank you, Dr. Wu, for sharing this great information. I only scratch the surface of some of these questions. I want to thank the audience for joining us and for these great questions. And also, if you didn't get your question answered, and you would like additional information or resources, please contact the Stanford Health Library. This presentation will be available through the Stanford Health Library and also our YouTube channel soon, very soon, a couple of weeks at most. I hope you can join us for our next lecture. Thank you.
Thank you so much for having me.
You're welcome. Good night.